Professor Lee, let me start with the first question. I think the estimation is that if you look at who is infecting who, that 50% of the new infections tend to come from acute infections and 50% are coming from chronic infections. I was wondering, in your analysis, are you able to confirm that, or are you actually able to put a timestamp on the infections?
That's a good question, but I think for epidemiological modeling, the more important thing is to be able to find the time point whereby one person's infection actually comes before another one. So that will allow us to draw a good modeling framework. Of course, understand the proportion of people who might be infected in the acute phase and those in the chronic phase. That is accounted for. So for whatever models that we put in, the strength or the importance of infection during acute phase of whoever that we have captured in the study will be accorded a priority. In fact, it will be stronger. So that will be one of the factors going into the model, yes. But whether we are able to confirm all of them, it's difficult. For some, yes, those with a seroconversion illness. But for the others, some of these are guesswork, some of these are extrapolation from the existing data that we have collected. So that's why it's always important to come up with a multidisciplinary approach. It cannot be just dry statistics in the laboratory, in the computer. It has, our study is actually composed of case cohort and the virus and laboratory studies, as well as some of the network analysis that we rely on information technology specialists to help us out.
So, and the other question is, if you look, and we did it in Europe, we look a lot at the phylogenetic networks, and then if you look at the data, my impression is that it all seems to be little epidemics, only vaguely related to each other. You don't see any dominant drives of certain strains, right? And but people then say that to really do this well, you need what they call dense sampling. So you need to know, you have to get quite a lot of your new infections in order to make a statement. And there, I think it ties in with the first presentation. How do you know that you're dense sampling? So what is the golden standard for dense sampling in the absence of putting a real number in the denominator?
Yes, that's another challenge. Of course, one way that we're dealing with it is using the our virtual cohort in Hong Kong, where we believe that almost all HIV positive individuals eventually get admitted into the healthcare system. So if we have that in mind, then of course at this point of time, there must be people who are infected but not diagnosed, or diagnosed but not known to the system. But you give it about, our estimation about 3 to 5 years. So what it means is we are very comfortable with data before 2010, and that will allow you to plot a very good curve and see what has been happening, except in the past 5 years. So that will be one means. And then the means would be to look at the sampling, as what Dr. Low was suggesting. So with the sampling frame that we are using, then we might need to do some extrapolation. Of course, some people who are not big fans of modeling would hate this way of making a lot of assumptions on assumptions, but that would also be another way of dealing with the problem.
I have a question for Ying, and I enjoy your presentation. I was struck by the slide you present about the Sentinel events for HIV, from negative HIV tests all the way to death. I'm wondering, it's like in the ideal population, for example, is a hepatitis C infection is a sentinel event. In the MSM population, is a syphilis diagnosis a sentinel event? I know in your group, you consolidated STI and hepatitis, but in the surveillance for HIV, I think it's majority of the country still have like stonepipe programs. And I come with a background in the U.S. that you probably heard about this Indiana story. In a small town, you have 190 HIV cases, but out of sudden sounds like explosive transmission, but molecular analysis show that, yes, HIV was pretty much after one introduction, and then the explosive transmission caused that a huge epidemic. But if you look at hepatitis C, they have multiple introductions over 5-10 years prior. And I looked at the surveillance data. In the US, the surveillance for hepatitis C is bad. It's so bad that only about 10% is acute cases are reported. But even with such an imperfect system, in the incidence of hepatitis C is actually increasing since at least 2012, so at least 3 years prior to the HIV epidemic we know. So I was wondering, is want to share some integration or some wishes you may want for like how to bring the Sentinel events even one step before the HIV testing and in the key populations.
Well, thank you very much. It's a very important question, and we have been discussing in our group, because WHO just recently released hepatitis surveillance guidelines for acute infection and also for sequelae. So we will most likely use the case surveillance, like the HIV case surveillance and also hepatitis B and C case surveillance, for both acute infection and sequela, monitoring of sequela, and combine that. And same for STI surveillance, it will all be case-based. That's probably, given the cost we invest, what all these integrated biologic behavior survey cost, and external funding is decreasing in many countries. I mean, in Europe, Australia, and developed world, many countries work on case surveillance, and that could be, and that should be applied for hepatitis B, C, and also for STI surveillance, but it has to be revived.
Okay, then there's another question here, but the question is, what is actually the importance to understand the dynamics of who infect who among MSM? So this is a question from the audience.
Sorry, so what's the question?
The question is, what can you do with the information if you truly understand the dynamics of HIV transmission in MSMs? What are the implications of that knowledge?
We are always, I think we are all greedy people. Of course, we all like to know all the information. But I don't think when you are setting up with a model to look at the transmission network, you need to know each and every bit of the history. That's probably not possible. It's very much like whether you can start doing a network analysis when you only have full data, whether you begin with your surveillance when you are comfortable with getting all the data correct 100% from 100% of the individuals. That's not possible. But of course, that is one factor that should be keyed in.
Yeah, so, but the question is more so, if you have a full understanding, just imagine you have a full understanding of the transmission dynamics of HIV, what could be the potential advantages with regards to interventions?
There's always an advantage if we are able to understand the characteristics of the networks. So, in fact, in our study, we normally, in the interviewing part of the history, we always ask individuals to state the time of the infection and where he has got the infection. It may not necessarily be the individual, but the type of partners that is actually more important. And then when we can characterize the network, then of course one important thing is, apart from looking at the transmission possibility, we're also looking at the chance of setting up tailored interventions.
So theoretically, you could intervene at the network, putting the positives on treatment and targeting PrEP on those around. But then if you look at the analysis Susan Buchbinder has done in the context of a PrEP study, numbers to treat and population attributable fraction of HIV infections, you can see that the numbers who were the numbers needed to treat with PrEP were highest in those with unprotected anal sex, but also who had sex with unknown HIV. So if you have a network, you don't know who has HIV, you have a very high risk of getting HIV. So it's probably difficult to say just target your interventions there. So it's complicated. Yeah. Difficult to say yes or no.
Yeah, so the issue is it's quite risky to target interventions if you're not completely sure that it's, yeah. It's a question in the back, microphone one.
Yes, Professor Lee. Hong Kong is part of China, obviously, and but then Hong Kong is also a special administrative region. So traditionally, Hong Kong people don't really move a lot. But from your data, do you have any idea of what's the proportion of the MSM network being, so to speak, local versus non-local?
That's a good and difficult question. It's very much like whether we know who has infected whom. I think at best, we can say that a majority of the infections really occur within Hong Kong. So it's not like the heterosexual epidemic that we're seeing, whereby 80% of the infection probably from somebody outside the city. So we are seeing transmission within the city, which is the key to the peak that we are seeing, or the escalating rise of the epidemic curve that we've been seeing. Of course, there are some where the infections has come from sexual contact with MSM outside the territory. And this can be inferred also from phylogenetics, because locally, I think we are seeing more of the genotype B, but if there's suspicion of contact or exposure to somebody from mainland China, that is normally other subtypes, either it's AE or subtype BC.
Yeah, I think that's quite similar to what we see in Europe. We run a network looking at newly diagnosed patients, and we genotype all their viruses. And we do that in 30 countries on an annual basis. And there we also find that most of the infections are actually acquired nationally. And it's very rare that, but it does happen that infections move from one country to another. But it's less international than we anticipated, actually.
And Professor Lee, if I could ask, how do you see increasing access to PrEP will affect the studies on transmission networks, and both for HIV and both for hepatitis C as well?
That's an extremely good question. In fact, as part of our coming research on the impact of PrEP. But it's a very difficult question for me to answer, because on one hand, even though I know that some MSM are probably looking forward to the access for PrEP, but PrEP is not yet available in this part of the world, or this part of my world in Hong Kong. So we don't have PrEP here. If we don't have PrEP systematically here, and we don't know how people view it, even though one studies from our research suggested that quite a different proportion are likely to come forward to take PrEP. But on the other hand, from a knowledge of MSM about what PrEP is still quite, not really quite satisfactory. But I agree that there should be one factor we should put into the study, especially on the modeling side, on the impact of PrEP on the transmission networks.
Question from Professor Prapan.
I have a question for Yingru. Just a naive question. Is there such a standardized method to estimate sample population size, and also to trace, from the cascade of care, from size, number of people might be infected, and so on and so forth? My question is there such a standardized method that being accepted by whatever organizations, WHO, UNAIDS, PEPFAR, whatever? And if so, who's in charge of this program or software, that any country would like to use that or learn how to do that, how to request for that? This is, it might be already existing, but I just wonder. Because I always heard that, the size estimation, the cascade of this and that country in this population is unreliable. So I just wonder, is there such a thing that is reliable enough that everyone will trust on that?
Well, as you probably know very well, is that there are standardized methods for population size estimates. There are models, modeling software which are provided by UNAIDS, and they are constantly being adjusted to also reflect the epidemic patterns and concentrated epidemics. They are not ideal at the moment because there are difficulties actually with epidemic patterns like in Asia. For the cascade, unfortunately, we haven't managed to develop these tools and and define the indicators. There's a process which is still ongoing, actually at WHO, to standardize the methodologies for case-based surveillance and also the cascade. That's still under development. There's no one authority, and it depends really on to develop those tools and forms together. And we are looking at the experience, we're collecting that in the different countries, but it's more difficult than we thought.
I have a question to Dr. Lee. I'm Nainko from Taiwan, and because many young generation they use their mobile phone application to seek their sexual partners. So my question is, how do you, the social networking application, how do it impact on the transmission network, and how do you apply the mobile application into either in estimation of disease or estimation for the social networks? Thank you.
Thank you for the questions. Actually, there are more than one question there. Let me deal with it one by one. One is about the mobile phones, whether it's affecting the networking or the transmission possibility or MSM. Yes and no. I think basically I'll look at it from another angle. So this is very much, mobile phone to me is a sauna. So many people are subscribing to one sauna. So you can assume that probably people who are more familiar or people who are big fans of certain apps will probably get closer to one another. So it becomes one network. And whether that network is more transmission prone, I dare not say. In fact, some of the time when we are doing this study, we are all assuming that people are communicating with one another, so there must be a lot of sexual activities which are unsafe. It can be the reverse. It can be the reverse that some of the people, because they are seeking casual sex partners, they become safer. So that is one answer to your question. The other thing is, how do we make use of the mobile phone apps when we are trying to do all these studies? Yes, I think this is one thing that we should work on. There are two different ways. One is, of course, the more broad general way of looking at mobile data. So I don't know whether it can be done in Taiwan. In Hong Kong, it's very difficult for us to get hold of mobile phone data. If that's the case, then perhaps you are able to do something on that. That's one means. The other means is actually setting up an app and doing something on top of that. But again, we have a sampling problem. So who is subscribing, who is working on who is using our apps will probably dictate the answers that you may not want to see, so it may not be the best way ahead. So those are some of the thoughts. I hope I answer your question some way.